Hello, doctors. I'm Dr. Chris Rapoff of QME Continuing Education, and welcome to this week's presentation. Today, I would like to provide a little refresher course for you on the difference between anatomic pain and non-anatomic pain according to the AMA Guides 5th edition. Now, first, I think it would be fair to say that an accurate pain assessment is really a critical aspect of a medical practice, as you're trying to strive and to ensure that your patients receive the appropriate diagnosis and treatment. So, how does that change when you're examining an applicant in a QME examination? Well, let's put this more practically. Have you ever performed a QME examination and you were actually baffled or confused by the examinee's description, the location, the intensity, and actually the type of pain? Have you ever asked yourself, how can this be? And this just doesn't add up? Well, you may be dealing with a situation where they are describing to you what is defined as a non-anatomic pain pattern. Now, we know that the AMA Guides 5th edition, specifically Chapter 18 entitled Pain, serves as the standard reference for evaluating pain-related impairment. But first, you must know what type of pain that you're dealing with. So in this presentation, we're going to explore the characteristics of anatomic pain and non-anatomic pain, highlight their key differences, and discuss their implications for pain assessment. And by the end of this presentation, you will have a clearer understanding of these two types of pain and their significance as they apply them to your career as a qualified medical evaluator. So let's get started. First, these are the following sources referenced when I was producing this presentation. I encourage you to explore these references if you'd like a little more in-depth understanding of our discussion today. Let's begin with anatomic pain. First of all, anatomic pain is described according to the AMA guides as a pain that can be attributed to a specific anatomical structure or injury. This type of pain is typically associated with observable and measurable signs, such as those seen in conditions like an obvious broken bone or a torn ligament or nerve damage. Okay, first, let's discuss the characteristics of anatomic pain. The first one, pretty obvious, but it's localized to a specific area, meaning that the anatomic pain can often be traced to a particular anatomic structure or region of the body. It's also observable and measurable. Typically, it's associated with an observable and measurable sign, such as swelling, bruising, or abnormal imaging, for instance. Predictable patterns. Anatomic pain often follows a predictable pattern related to a specific structure that's involved with. For example, nerve pain might follow the distribution of the nerve. And the example of dermatome, and you see the dermal chart on the right. Producible physical examination findings. This anatomic pain can usually be produced or exacerbated by specific physical movements or tests during a clinical examination. And also, it's consistent with an anatomical injury. This pain is consistent with clinical findings and diagnostic imaging results that are related to an anatomical injury or pathology. Now, it also responds to treatment, or the response to treatment, I must say. Anatomic pain often does respond to treatment that targets the underlying anatomical issues, such as surgery, physical therapy, or even medication. So these characteristics help the healthcare provider and the QME identify and assess anatomic pain, leading to a more accurate diagnosis, effective treatment plan, and an accurate permanent impairment rating. Now, I'm providing several examples of anatomic pain for you. And let's talk about fracture. First of all, the pain resulting from a broken bone. It's usually a sharp, localized to the area of the fracture. Also, arthritis pain. This pain is due to an inflammation of the joint. This can cause stiffness, swelling, and discomfort in the affected joint. Tendinitis. Pain is caused by an inflammation of a tendon, often due to overuse or injury. Common areas include the shoulder, elbow, and wrist, and we think of CT injuries here. Sciatica, pain that radiates along the path of the sciatic nerve, which runs in the lower back to the hips, down the buttocks, and down each leg. It is often caused by a herniated disc or a bone spur that compresses the nerve, obviously. A disc herniation. Pain resulting from a disc herniation or a bulging disc in the spine can actually be caused by a pressure on a nearby nerve, and it can cause significant discomfort, as we all know. Carpal tunnel syndrome. Pain and numbness in the hand and arm caused by the compression of the median nerve as it travels through the wrist. Rotator cuff tear. Pain resulting from a tear of the muscles and the tendons that stabilize the shoulder joint. And a nerve pain or a neuropathy or radiculopathy. It's pain resulting from damage to the nerves, often described as a burning, tingling, or shooting pain. Now, these examples highlight the pain that can be traced to the specific anatomical structure or injury, making it characteristic of an anatomic pain pattern. Okay, now let's contrast this with non-anatomic pain. First of all, non-anatomic pain, according to the AMA Guides, 5th edition, is defined as pain that cannot be attributed to a specific anatomical structure or injury. This type of pain often lacks observable signs and measurable indicators, making it more challenging to diagnose and assess. And some examples we will discuss, but one of them is fibromyalgia and chronic pain syndromes. Now, discussing the characteristics of non-anatomic pain, well, first of all, we discuss that it does lack specific anatomical origin. Non-anatomic pain cannot be traced to a specific anatomical structure or injury. It's also diffuse and widespread. Pain is often diffuse, affecting multiple areas of the body and can change locations. There are no observable signs. Unlike anatomic pain, non-anatomic pain lacks observable signs and measurable signs. Diagnostic tests and imaging usually do not reveal any abnormalities either. You do have subjective symptoms, though. The pain is primarily based on the patient's subjective report and experiences, making it harder to quantify. Also, it's chronic. It can be chronic, and non-anatomic pain often has this chronic nature that persists for extended periods of time and sometimes even years. And we will discuss a few of those types of pain. It's associated with psychological factors many times. So it's often linked to psychological factors such as stress, anxiety, or depression, which can exacerbate the pain. Also, we have an inconsistent response to treatment. Non-anatomic pain may not respond predictably to conventional treatments for pain, and managing it can be even more challenging. And also, functional impairments. It can lead to significant functional impairments affecting one's ability to perform activities of daily living, despite the absence of clear physical findings. And finally, pain behaviors. Patients may exhibit pain behaviors such as a grimacing or a guarding, even without any clear anatomical reason for the pain. So these characteristics that I just mentioned do make non-anatomic pain much more complex to diagnose and manage, and it requires a really comprehensive and multidisciplinary approach to treatment many times. Okay, so some examples of non-anatomic pain include fibromyalgia. Now, fibromyalgia is a condition that's characterized by widespread musculoskeletal pain, fatigue, and tenderness in localized areas without really any clear anatomical cause. Okay, chronic fatigue syndrome. And that disorder is marked by extreme fatigue that does not improve with rest and cannot be explained by an underlying medical condition. We have chronic pain syndromes. These are persistent pain syndromes that last beyond the usual course of an acute injury or illness, often, again, without a clear anatomical cause. We have somatic symptom disorder. Now, this is a mental health condition where a person has significant physical symptoms, such as pain, without a clear medical explanation. Now, you see this image on the right. Now, this can encompass a number of other disorders, including, for example, body dysmorphic disorder, conversion disorder, or conditions of hypochondriasis or hypochondriacs. Okay, complex regional pain syndrome, or CRPS, as we know from the AMA guides. We know that this is a chronic pain condition that affects a limb after an injury or a surgery, with pain that is really out of proportion to the initial injury and really can't be attributed to a specific anatomical structure. We have nonspecific low back pain, chronic back pain that doesn't have a specific anatomical origin or a clear diagnosis. Tension type headaches. These are headaches that result from stress or tension rather than a specific anatomical cause, characterized by a dull, aching and pain in the head and the neck. And finally, medically unexplained symptoms, MUS. Physical symptoms that lack a clear medical explanation and that are often associated with psychological factors. So these examples really do illustrate that pain that cannot be traced to a specific anatomical structure or injury makes them a characteristic of a non-anatomic pain pattern. Okay, so now that we've discussed the differences between anatomic pain and non-anatomic pain, we defined them, we gave some characteristics and examples. So let's now talk about what assessment tools and methods that we use for pain assessment according to the guides, 5th edition. Now, pain assessment tools and the methods according to the AMA guides are really designed to evaluate the impact of pain on an individual's overall function and quality of life. These tools also can provide an additional insight to the individual's perception of pain themselves. Some key tools here and methods that are used currently. So the pain assessment tools, number one, is the Pain Disability Questionnaire, the PDQ. Now, this tool assesses pain-related impairment by evaluating the extent to which pain affects daily activities and overall functioning. Now, this is also described in Chapter 18 of the guides. We have a pain severity scale, also known as the Visual Analog Scale, or VAS, and it's used to rate the intensity of pain, typically from 0 of no pain to unbearable 10 worst pain possible. Another one is a pain mapping diagram. These diagrams allow the patients or the examinee to mark location and intensity of the pain on a visual representation of the human body. And another, functional limitation evaluation. These are assessments that evaluate the degree to which pain affects an individual's ability to perform daily activities. Many times these are ordered or prescribed for an examinee that has had a QME examination or will have an examination. All right, so what are the methods of pain assessment according to the guides? Well, first of all, the objective findings. These are the observable and measurable signs such as swelling, bruising, or abnormal imaging findings that support a diagnosis of anatomic pain. We have subjective symptoms. These are the patient-reported experiences of pain, often used in the assessment of non-anatomic pain. Credibility assessments. These are evaluating the credibility of the individual's reported pain, considering factors such as consistency with clinical findings and the impact on daily activities. We move on to whole person impairment. You can actually add up to 3% whole person impairment for pain that exceeds the expected levels based on the Pain Disability Questionnaire that we discussed earlier. And the last one is a maximum allowance. We talked about this additional 3% whole person. Well, the maximum allowance for pain resulting from a single injury is 3% whole person impairment, regardless of the number of impairments resulting from that injury. So, as we learned today, understanding the distinction between anatomic pain and non-anatomic pain, as outlined in the AMA guides, is really crucial for a QME to provide an accurate diagnosis of an injury for an examinee, and ultimately the most accurate permanent impairment rating to provide.
Now, just to review again, anatomic pain is directly related to an identifiable physical damage or pathology, whereas non-anatomic pain lacks such clear physical origins and is often more challenging to diagnose and manage. Now, we need to recognize these differences as they really are essential for us improving the patient outcomes and also guiding us as QMEs for a proper impairment evaluation. Well, doctors, I'm Dr. Chris Rapoff. I wanted to thank you for taking the time to join me in this presentation today. I hope you enjoyed it, and I do look forward to sharing other interesting subjects as they relate to the workers' compensation system in the state of California. But until next time, thank you.